Professor Afsif Nair from AMU. You are welcome here, sir. We are going to start shortly today's session. Professor Tully will give his talk on tubercle arthritis of hip. Sir.
Friends, yesterday we talked about TB of the spine. Today, coincidentally, it is tuberculosis of the hip joint. Yesterday we mentioned that TB of the spine is the commonest location of osteoarticular disease. 50% of TB of the skeletal system occurs in the spine. Taking a clue from the same, as students we have to learn many things. So if we say 50% of tuberculosis occurs in the vertebral column, 20% occurs in the hip joint, 10 knee joint, 5 foot and ankle, 3 wrist and hand, 2 elbow, 1% in the shoulder, and remaining a few percent, tuberculosis can occur anywhere in the skeletal system, right from the skull to the great toe. Though skull, though skull, ribs, clavicle, pelvis, they are all rare sites, but one should know that tuberculosis can occur anywhere in the body. This slide was shown yesterday as well, and it was mentioned that tuberculosis in the West reduced to this level much before the availability of the chemotherapy and anti-TB drugs. Anti-TB drugs and BCG. The tuberculosis came down from this high incidence in the European countries to this level, not because BCG was available, not because ATT was available, but just because the nutritional status of the society improved, cell-mediated immunity in the society improved, the incidence came down. In 1980s, we were under a impression, a short-lived impression, a short-lived optimism that the disease may disappear from the earth, but it was a short-lived optimism. The reason why a large number of people started appearing in the world with lower cell-mediated immunity, so-called CMI. The CMI comes down with aging itself. The moment you cross 65 years of age, your CMI, cell-mediated immunity, goes down. People with HIV, people with diabetes, people on steroids, people on cancer chemotherapy, people on chemotherapy for rheumatoid disease, chemotherapy for organ transplantation. All these things bring down the CMI. I'll be using the word cell-mediated immunity as CMI, please. Besides that, nutritional status itself brings down the CMI. And so long as there are pockets of deprivation in the world, tuberculosis will exist. Tuberculosis in the skeletal system will occur in about 3% of patients of all tuberculosis. There are difficulties even in diagnosis of tuberculosis. Bone and joint tuberculosis is a paucibacillary disease. The number of the bacteria is so small, it's so difficult to harvest them. In our experience in the northern part of the country, we have an experience that it is in less than 20% of patients that you can actually harvest mycobacteria. In other patients, we depend upon clinical presentation, laboratory findings, and histology. PCR is one of the serological tests which has some value. Doing a Mantoux test is of no value. In the northern part of the country or the Indian subcontinent, Mantoux can be false positive as well as false negative. It's of no value. Whereas the only serological test which is of value is PCR. Again, if we look at it, the PCR must be positive from a tissue which is clinically inflamed. It is if the material has been obtained from a clinically inflamed area, then the PCR positivity matters. A negative PCR, again, does not exclude tuberculosis. These are broad things which we must know. At present, the situation is a negative PCR does not exclude tuberculosis. Positive PCR obtained from an inflamed tissue is very high sensitive test that probably this is tuberculosis. Hip joint tuberculosis, one of the commonest deformity which a hip joint tuberculosis causes is a fixed flexion deformity. This child shows you a fixed flexion deformity, and the child is trying to hide the deformity by creating a hyperlordosis at the lumbar spine. The patient is hiding the fixed flexion deformity by creating a exaggerated lumbar lordosis. If we can manifest the fixed flexion deformity by lifting it up, lift up the deformed hip joint, create its original fixed flexion deformity, undo the lumbar lordosis, and this is how we demonstrate the degree of fixed flexion deformity in the left hip joint. Another method, the classical method is the Thomas test. Flex the normal hip joint, flex the normal hip joint, undo the lumbar lordosis, and the fixed flexion deformity will make it manifest. This is one of the commonest deformity which occurs in the hip joint, in the tuberculosis of the hip joint. One deformity which is slightly different than the deformities in different stages is flexion, abduction, and external rotation. We will come to it in a minute. And as we were mentioning yesterday, that whenever you get a patient of tuberculosis of the hip joint, or for that matter tuberculosis of any joint of the body, try to get an X-ray along with an X-ray of the chest. You are sending the patient to the X-ray department. As students, as clinicians, we are sending the patient to the X-ray department. So difficult to transport patients in our country in an average hospital. So he is going to the X-ray department because the patient has an infection in the hip joint. Also ask for an X-ray, PA X-ray of the chest in the same go. Most of the X-rays can be done with comparative normal joint, except shoulders. You are suspecting knee joint tuberculosis, send the patient to the X-ray department. Please do both knees together in the same exposure, so you can detect the earliest evidence of abnormality. X-ray of both the ankles in the same exposure, identical X-rays in the same exposure. Fortunately, hip joint can also be done the same way. And look at this one. This is the hip joint. This is the X-ray of the hip joint. And this is the normal one. You can appreciate that there is something wrong in the right hip joint. And many a time, the X-rays overlap many other pathologies. Yesterday also I mentioned that sentence ad nauseum. TB can mimic any pathology, and any pathology can mimic tuberculosis, both clinically, radiologically, even in MRI. Histology and micro is a different thing. They are the ones which can give you a more reliable information. This X-ray doesn't look different than tuberculosis. Diminished joint space, eroded para-joint margins, severe osteoporosis, and it is a patient who had severe injury to the pelvis. You can actually see the evidence of injury here, that the patient had a fracture through the pubic bone. And this patient came to the hospital like that. A biopsy was done, just to be sure, are we dealing with tuberculosis in a patient who coincidentally had a fracture? No, it turned out to be a post-traumatic reaction in the bone. So kindly keep it in mind. One, X-ray of both the joints is possible. Except shoulder, it's possible in every joint. Ankle, knee, hip, wrist, elbow. You can always get an X-ray done. Both the joints identical, and then an X-ray of the chest. Now we come to MRI. Even MRI of a joint is non-specific. This MRI picture can be present in many conditions. This can be present in a pyogenic infection, can be present in tuberculosis, can be present in rheumatoid, can be present in transient synovitis. So even MRI is non-specific. And what are we seeing here? Yesterday we talked about it, that T2 water white, this is all water. It is an MRI showing white collection of water. This is water, the fluid. This is the edema in the bone, and probably there are some lymph nodes here. So, but this is non-specific. It can be tuberculosis, pyogenic infection, rheumatoid, hemarthrosis, post-traumatic. All this can almost look like this. Here is another example. Here is also, you can see the MRI. The hip joint shows effusion, but this was a patient. He was not tuberculosis, but he turned out to be a transient synovitis of the hip joint, which we all know can occur in childhood due to non-specific causes, observation, anti-inflammatory, supportive therapy, and most of them resolve. And here is the X-ray of the same patient, resolved. And if you can put the patient hip joint into frog position. So we have taken an X-ray in the frog position, wide abduction, external rotation, flexion. If you can put a hip joint into this position, probably this hip joint is practically a normal hip joint. Do keep it in mind. If a patient comes to you with pain in the hip joint, limping in the hip joint, do keep it in mind. Something outside the joint, juxta-articular lesion. See, we discussed about a painful limp, a pain in the hip joint. Keep it in mind that there may be a pathology in the hip joint, or there may be a juxta-articular disease. In this particular patient, we have a patient who was limping. An X-ray of both the hip joints was done, and this patient showed that the cause of limp and pain is a very rare condition, so-called Pgte's disease in this particular patient. In Pgte's, what you get is a mosaic appearance of the trabeculae. The trabeculae do not have the normal structure or the normal lay. It's a mosaic position. Here is another example in a child, a limping child who had an osteoidostoma. There is an osteoidostoma in the pelvic bone. The patient had pain and limping. So keep it in mind, disease may be in the hip joint, maybe around the hip joint, and we have to keep all this in mind. And if you had not taken a comparative X-ray, you could have passed this hip joint as normal. Another example to show you again the same thing. A hip joint, tuberculosis can mimic anything, and anything can mimic tuberculosis. Here is a patient who has typical avian-like appearance. Geographical appearance in the MRI, best shown in MRI stage 1, MRI image T1. Image T1 in the MRI is the investigation which will show you avian in the earliest stage. Avian in the earliest stage would be seen as a geographical appearance in the femoral head, or crescent-like thing parallel to the border of the femoral head. In the MRI, this is the typical picture of an avian or a geographical appearance in the femoral head, as if somebody has made a geographical map. So these are the classical picture of avian. Patient was operated. The patient got this. We knew that the patient has an avian because he was put on steroid for a very long time in a ICU care. So, as a standard operation, cold decompression, bone grafting being planned for the avian. On the left side, it was avian. On the right side, it was avian, again associated with tuberculosis. So, again emphasizing that tuberculosis can mimic any pathology, and any pathology can mimic tuberculosis. Here is another example, a young man or a young boy being treated for tuberculosis, large lytic lesion, patient on ATT, not recovering. If a patient does not show a favorable response in 4 to 6 weeks' time of effective standard anti-TB drugs, think of a second possibility. And in this particular patient, because the patient did not respond, an operation was performed, and we found that this And we didn't know at that time that we are packing up with a allogenic bone graft or a bank bone graft. It ultimately turned out to be an eosinophilic granuloma. Again, emphasizing the overlapping clinical, MRI and radiological picture of a pathology of tuberculosis related to skeletal system. Differential diagnosis is very important at early stage. When the disease is advanced, probably differential diagnosis becomes not very difficult. But these are some conditions which resemble each other in differential diagnosis. It can be traumatic synovitis, transient synovitis, rheumatic rheumatoid disorder, low-grade pyogenic infection, iliospasm due to an abscess or overlying infection in the iliopsoas area, Perthes disease, slipped capital femorphysis, AVN, bleeding disorder. Failure to clinch diagnosis by non-invasive or semi-invasive investigation mandates tissue diagnosis. Don't hesitate. Do an arthrotomy. Reach the diseased tissue and obtain the tissue and send it for examination. What tissue will you obtain? What tissue one should obtain? Every tissue. Capsule, synovium, suspected piece of bone, regional lymph nodes, fluid. Send all that you can. There's a crude statement being projected these days. When you do a biopsy, send it for culture as well. When you obtain a tissue for microbiological examination, send it for histology as well. This is a crude statement being made these days. So anyway, we open up a joint, capsule, synovium, piece of bone, fluid, regional lymph node, all the 5 tissues. For what? For histological examination, microscopic examination, and microbiological examination, and serological examination. Osteoarticular tuberculosis is very difficult to make diagnosis. Many a time we will fail to obtain a positive response microbiologically as well as histologically. Then you make a treatment on best possible guess. And this is permitted, written. But you have to show. We live in a different world now. See, there was a time when a medical man was considered near God. Not today. Today, whatever you are doing is under scrutiny. And who puts you on scrutiny? Many of us. We will put you on scrutiny. Lawyers put you on scrutiny. Some of the doctors are becoming lawyers. They put you on scrutiny. Why does a doctor become a lawyer? Because he has to do only thinking and writing, nothing else. He makes as much money, probably more money. So they are called ambulance chasers. So there are many doctors who are becoming lawyers to play this game of scrutiny. So when we are subjected to this scrutiny and when we are in difficulty that histology does not show tuberculosis, no case-getting granuloma. Microbiology, no AFB detected. PCR still negative. You are starting anti-TB, but you have to show that you did all these tests on paper. You must show that you did a biopsy, send it for histology, send it for PCR, send it for microbiology. Still, the report is non-contributory. Let me accept it as tuberculosis, but having done all these tests. So this is how you will save yourself in the court of law. Tuberculosis in the hip joint may start anywhere. For that matter, any articular tuberculosis can start anywhere. Synovium or the bones. In hip joint, it can start in acetabulum, femoral head, greater trochanter, and Babcock's triangle. It is advisable to put the infection in the hip joint into different categories. Stage 1, 2, 3, 4, 5. One can put it like that. Now this classification which is being shown in this chart is almost like a universal classification for any arthritis, any disease of a joint. Maybe tuberculosis, maybe pyogenic, maybe rheumatoid, maybe bleeding disorder. Think of any. Every arthritis should be classified into these stages. No classification is perfect, children. No classification is perfect. But the idea is put it in classification so that we can communicate in the same language. One man writes, all my patients of TB spine, they recover, TB of the hip joint recover with full recovery. He may be dealing all of them with synovitis. If you are dealing with synovitis, probably you will find that synovitis will recover completely. But there is another fellow who says all my patients of TB of the hip joint end up in fibrous ankylosis. He may not be dealing with synovitis, but he may be dealing with advanced arthritis. Beta, can you help me with an arrow here? ये arrow नहीं चल रहा है? Okay. हाँ आ गया. Sometimes it misses, It needs an techniques which I do not know many. So at synovitis, this is the only stage where the hip joint will have a deformity of flexion, abduction and external rotation. This is the only stage. Flexion, abduction and external rotation. Why? Because that gives you maximum space within the capsule of a hip joint. When we move from synovitis to early arthritis, advanced arthritis with subluxation dislocation, the deformity is flexion, adduction and internal rotation. In general, again there are exceptions. So, in the very first stage, the flexion, abduction, external rotation, and in all other stages, the deformity is flexion, adduction and internal rotation. Radiologically, tuberculosis of the hip joint can be classified into different categories. Again, a classification offered by Dr. Shanmuga Sundaram. We have just slightly modified it. So this is adapted from Shanmuga Sundaram. It can be a normal hip appearance. You will see all these as I pass through the images. A sort of a wandering acetabulum, dislocated hip joint, Perthes-like appearance, because sometimes tuberculosis can lead to endarteritis or thrombosis of the blood vessels to the femoral hip joint, or protrusive acetabulum, or atrophic or coxa brava sort of thing. All these varieties can be seen in our country because we happen to see the natural course of the disease. These things won't be seen in affluent countries. They will see most of the patients probably at the stage of normal or traveling acetabulum type, not more than that. In our country, we can see all varieties. We were mentioning a few minutes ago, here is classical appearance of, I think, something like stage 2 or stage 3. Gross destruction of the joint, eroded para-articular margins. Same patient had an MRI available, shows you a collection in the pelvis, in the acetabulum, and a supporting lymph nodes in front. Patient had pulmonary tuberculosis as well. A young lady, and she was just treated. Now we go to treatment. Basically, treatment is give rest to the joint in the best functional position. As students of orthopedics, we must know what is the best functional position of every joint. Every joint we must know what is the best functional position of a particular joint. Give rest to the part in the best functional position. Put the patient on anti-TB drugs. When the pain is less, subject the patient to active assisted exercises. Aim somewhere in 59, 60, the aim at that time used to be permit the joints to undergo fusion, except fused joints, ankylosed joints. But that was the philosophy before 1960s. Today the philosophy is obtain a healed status with a mobile joint. So give rest to that joint in the best functional position. Put the patient on effective multi-drug anti-TB drugs. As the pain subsides, subject that joint to functional arc of movements depending upon the tolerance of the patient to pain. And you can get many patients in a healed status with a functional arc, retention of movements in a functional arc In many cases you will be able to get it. And this has been given the name of functional treatment of articular tuberculosis. If you have the facilities, then in patients like, in lesions like tuberculosis of the hip joint and knee, one may use traction to maintain the joint space for some time. But traction confinement to the hospitals is being debated, but one can apply traction, maintain the joint space, and subject the patients to active assisted exercises. This particular patient, you can see have a look on the X-ray at the time of presentation, have a look on the X-ray of this patient 1 year after. You can see the remarkable repair which can take place in a patient of tuberculosis if you treat them well. What looks like eroded bone, it is eroded all right, but essentially it is demineralized. Probably matrix is still there, and by effective anti-TB drugs one can see all this bone has been reconstituted. This is the same patient. We have followed her up now for 15 years. She is a young lady with a mother and all that. These examples can be multiplied. Look at this one, presented 1966, probably stage 2, gross diminution, erosion, osteoporosis, on treatment, functional treatment. Roughly 15 years after, the disease has healed, but the femoral head has undergone coxa magna. What is coxa magna? A large head. How do you get a coxa magna? If the blood supply of the femoral head has remained increased for a few months and years, it can get a large head called coxa magna. It can happen in tuberculosis. It can happen in low-grade pyogenic infections. It can also happen in Perthes. In Perthes also, when the healing takes place, there is increased vascularity in the femoral head and you can get coxa magna. And this very patient, say roughly 40 years after his attack of TB, is like this. All these patients ultimately will get degenerative changes. But look at this one. He has lived with this joint for 40 years. He is still able to sit like this roughly 40 years after the original disease. So if you can treat them well, diagnose, treat them well by functional treatment, today you can provide a mobile joint, though one day he may require a replacement of the joint for a painful degenerative osteoarthritis, and this is degenerative osteoarthritis, coxa magna not leading to, associated with degenerative changes, which are increased density in the para-articular margins, and in this very increased density you find subchondral cystic changes. Here is a subchondral cyst, here is a subchondral cyst, here is a subchondral cyst. This is what is degenerative osteoarthrosis. We'll see another example. Child, what looks like a protrusio type, grossly destroyed. This can be called coxa brava according to Shanmuga Sundaram classification, and in due course of time the disease healed. This 2 years after, healing has taken place and we have left behind a scar here, mobility the child could get. Another example, Perthes-like. See, we saw in the initial stage we talked about the Perthes-like change. Here is the Perthes-like change. Tuberculosis, metaphyseal osteoporosis, increased density of the epiphysis. This is the epiphyseal cartilage, that the epiphysis, increased density. Patient was put on treatment and the patient healed again with coxa magna, though coxa brava as well. The neck remains short. Is it tuberculosis? You can beat or discuss it. The patient had pulmonary lesion. Patient also has a disease in the pubic bone. This is tuberculosis of the pubic bone, a cavity with a small scustum, which also healed in due course of time. Another example of tuberculosis of the hip joint is sort of a protrusio variety. Patient healed with almost reconstitution of the diseased area. Another patient, I think there are many examples which we can keep on. This is something like a fibrous ankylosis, gross diminution of the joint space, secondary early degenerative changes take place, But the function of the patient is good. The patient is sitting like that. Once this hip joint become painful, this is again degenerative osteoarthrosis in the hip joint, the typical one which I showed you earlier. And ultimately these patients may require a total hip replacement so long as he can manage. He has managed for 40 years, 50 years. Once they cannot manage, then one can do a total hip arthroplasty. The minimum requirement for a total hip arthroplasty or a total knee arthroplasty is a healed status of the disease at least for 3 years. This is the standard being followed at this time, standard international standing. However, there are many brave amongst us who may do it any time. But otherwise, as a student, we should know for minimum healed status for 3 years, healed based upon clinical, laboratory, MRI, X-ray findings. The patient has remained healed for 3 years. You can consider such patients for joint replacement. Guidelines, indications for operation in tuberculosis of the hip joint. That may be too much. This is an example of a girdlestone axial arthroplasty in which, in an adult, ideally this operation should be done in an adult, excise the diseased femoral head, shape the distal part of the, shave the distal fragment or the proximal end of the femur into a shape which is parallel to the pelvic bone, and you can give a mobile, painless hip joint, though it is somewhat unstable and there is an increased shortening of about 1.5 to 2 centimeters. But this is one-time operation. Majority of the patients working in the rural area are prepared to accept it. This is the grossly destroyed hip joint. This is what happens. If hip joint is grossly destroyed, what happens to it? You can see the hyaline cartilage gets eroded. In the initial stages, it may be a small part of the hyaline cartilage which gets eroded, but in the later stages, a gross erosion of the hyaline cartilage, and underneath you can see the naked bone, the subchondral bone is visible. This is the destroyed hip joint in a patient in whom a girdlestone procedure was done. I think that may be good enough. So do an operation when there is a gross diminution of the joint space, gross limitations, and the patient is an adult. Axial arthroplasty should be done only for those reasons. And many a time, a girdlestone can leave behind an unstable joint. There are many procedures which are described for it, something like shelf procedure, tectoplasty, pelvic support osteotomy, or a shelf operation. I think these are matters of detail which we can leave for future. What does girdlestone axial arthroplasty? Pros and cons. All floor activities are possible, can manage as one-time operation, mostly requires a walking stick when walking outdoors. Trendelenburg sign still remains positive. Approximately 2 centimeters shortening is added to it. So this is what you get in a girdlestone axial arthroplasty, which can be done in a grossly destroyed hip joint in a patient who is an adult. Arthrodesis. Another option is do an arthrodesis. Arthrodesis was an accepted operation, but arthrodesis puts so many limitations on us. As students, we should know what does an arthrodesis do. It permits you normal chair and commode activities. One can manage most of the activities as a one-time operation. However, any major joint fusion, any major joint, it's a hip joint or a knee joint or even lumbar spine, any major joint fusion will lead to juxtafusion disturbed kinematics, leading to juxtafusion joint early degenerative changes. Hip joint fused, you will putting extra strain on the knee, spine. Opposite hip, ipsilateral knee. Here is an example. Fused hip joint, probably done by a person like myself about, I think, 60 years ago. Patient lived for very good, and Due to a minor injury, she first broke her tibia, and then came the turn of breaking her femur. Everything is under stress, and she also has degenerative changes in the spine. So any major joint fusion does lead to stress concentration in the neighboring joints. Hip, knee, lumbar spine, they are the most notorious areas. We should accept fusion with reluctance. Then we go to total hip arthroplasty as one of the possibilities of treatment. Fairly mobile and painless hip joint. But keep it in mind, average life is about 12 to 15 years, which may need a revision. Reactivation of infection can occur in 5 to 10% of patients. Normal activities in chair and commode are possible. No floor activities. This is the pros and cons of a total hip arthroplasty. So, girdle sternocleidomastoid arthroplasty, fused hip joint, and total hip arthroplasty. These are the three main operations possible are discussed in a young adult who has a grossly destroyed hip joint due to tuberculosis. I think I would leave it at that place. The rest are all complications. I thank the organizers permitting me to share some of my thoughts, and I thank you, my young friends, for your attention.
Thank you very much, Professor Tulli. We feel privileged sitting here and listening this lecture from you. I'll ask the students to ask any queries if they have on this very important topic, which is a must in MS Ortho exams. So I had one question to start with. Some people are doing total hip replacement after negative ESR and CRP. So that is the criteria, not 3 years. So what is your opinion about it? That a CRP as a marker will be negative and ESR will be within normal ranges.
Sir, all serological tests are unreliable. Even WHO has come out for international information. No serological test is reliable either from blood or from the fluids except PCR for tuberculosis. Nothing else is reliable. False positive, false negative things are possible. Yes, sir.
Student first, clear your name and institute.
I am Jaya Venkatesh from Kilpak Medical College, Chennai, sir. If at all we have to do biopsy for hip joint, which approach is preferable, sir? A direct anterior approach or a anterolateral approach?
I think unfortunately hip joint can be approached by any approach. There are anterior approach, anterolateral approach, posterior approach. Whichever you are used to or you are familiar with, you can do. Which one I do? If there is no gross displacement of hip joint, we go through anterior transverse incision. It is an incision given transversely from the palpable femoral artery to the top of the greater trochanter. Cut the skin, superficial fascia. D fascia you can slit longitudinally. And you are now in a place, shift rectus femoris laterally and all the other structures medially. Think of it. Think of your femoral triangle, feel the femoral artery. You have given a horizontal incision, skin, superficial fascia, D fascia. In the D fascia, cut longitudinally. You don't have to cut it, split it. Split it up to the inguinal ligament and down as much as you like. It is in the fibers. Now shift tensor fascia lata laterally and sartorius, femoral, all the big blood vessels, femoral artery, vein, nerve, shift to the medial side and you are in front of the capsule. But this approach has to be learned by apprenticeship. It is given in the book. I did, and I learned it from Dr. Sureshwar Pandey, Ranchi. He discussed with me once, and it is from him that I learned, then we developed it. Today we use it very frequently for moderate procedures on the hip joint. You cut no muscle. There is only a vessel when we start cutting the capsule. Take the tensor fascial aorta laterally, sartorius and all the median structures medially. You are in front of the capsule, cut the capsule longitudinally, parallel to the neck, you are in the hip joint, remove capsule, synovium, piece of bone, fluid, lymph node, and send all this tissue for all the tests. It's the easiest approach, sir. You people are children, you are learning, and if you learn it, I'm sure you'll be able to manage this one. But 1 or 2 times you have to see. We have all learned as apprentices. We learn from our teachers and gurus. Though we forget them, but we have to learn it that way. It's an apprenticeship. It's a game of doing. You can do every procedure with this, except probably a total hip replacement. You can do every procedure through this approach.
Thank you,
Yes, sir.
Thank you very much, sir. Sir, I would like to request you and Dr. Dhananjay Taneja sir and Dr. Mehtani sir, as an examiner, as all of you know, this is the most common case or clinical entity which is kept in the examinations for long case very oftenly. What are the most liable question, most likely question and possible question you would like to ask from the student? And Dr. Tuli has to answer that. Sir. Dr. Taneja sir, DKT sir. From the student. Tuli sir has to be answered so that everything can be crystal clear.
You see, the 70% of the students
Yes, sir.
will get hip as a long case. Please remember that.
Exactly. No doubt.
Now, most of the time, a lot of time is wasted by the students when we are on the examination. And there are few things where the boys stumble.
Exactly.
Is adduction deformity, abduction deformity, how do you square the pelvis, how is the Perkins method, what is the Kothari's method. They all start fumbling onto this thing. Apparent measurement, real measurement, all these things. How do you test the movement, lumbar lordosis, what are the fallacies. Lot of questions are asked on the examination, clinical examination.
Exactly.
And therefore, in all our PG courses, we devote lot of time on the hip examination, and we first teach you, demonstrate you, and then we ask you people to do that examination in front of the examiners, and we try to bring out these things. Then the next stage comes, once you have gone through it, we just ask you what is your clinical diagnosis. Okay, they're very set question. Clinical diagnosis, you should be able to. Then we say why you think it is your clinic. You must logic it out. There is a case of tuberculosis of hip, you think it is a Perthes disease. Okay.
Exactly.
No problem. But you must logic it out that why I think it is a Perthes disease. So we want to test your logistics. That's the one thing. Differential diagnosis, 2 or 3 you must be able to give it. And then you say, we ask you the question, what will you do next? The people start doing MRI and all this. No. The first thing you all always do as a student is ask for an X-ray. You are an orthopedic student, and as an orthopedic student, the first thing we always do in the outdoor is a X-ray. We don't send the patient to get a CRP done or ESR done. Get an X-ray. So you try to, then we ask you to read the X-ray. Then we ask you what you will do it. Does it confirm your diagnosis? You say yes. Then we ask you what is the management. And management, you should be able to tell, sir, I am going to do a THR, girdles, or whatever it may be. And again, you must try to justify your treatment, and that is what they say. In the examination, if you are a DNB student or an MS student, the procedure is that we give you 20 minutes to examine the case, and 20 minutes are given for the biopsy. So that means in a long case, you get about 40 minutes. So please remember that. In those 20 minutes, you have to finish your history and everything within 5 to 7 minutes, not more than that. So that the rest of the 15 minutes are left for us to discuss the case. Okay? Is that clear? Fine. Good.
Any question from the students? They would like to clear their doubt regarding a hip joint. Third year students, those who have seen the examination in their own centers and the students' difficulties during that examination, in regard of that and relation of that, you have to ask, so that the fundamental or your problem can be solved here. I would like to simplify the question pattern of the students. You have to ask the problem about the examination. Treatment, approach, all these things are written in the well standard book and references. But no question, no answer is written in the book. Okay, sir, Tuli sir, how will you decide the treatment of tuberculosis, hip joint?
So, how to decide the treatment option for adolescent tuberculosis with healed one? If a patient is having fibrous ankylosis, whether we have to tell about ankylosis or orthodosis or totally replacement, whatever. How to decide?
I think as a student, in the examination, you are going to discuss the possibilities. As Professor Taneja mentioned, we discuss a differential diagnosis. We don't stick to one diagnosis. Sir, most probably the diagnosis is tuberculosis or an infection or a monoarticle rheumatoid. But sir, I like to keep them in differential diagnosis in that order. Similarly, when we come to treatment, let's say what the patient has. The patient has a fixed flexion deformity in an unacceptable position. Patient wants to improve upon it. Sir, there are three possibilities. If the patient wants a one-time operation, there are only two. One-time operation, Girdlestone. One-time operation, arthrodesis. But we know the pros and cons. Sir, in Girdlestone, the patient will get another additional 1.5 to 2 centimeters of shortening. When he is out of door, he is going to use a stick in the opposite hand. However, a man who needs to do, we use the word, floor activities. One has to economize even on the expression there. Now, what do you mean by floor activities? To be able to squat on the floor, to be able to sit with crossed legs, to be able to work from the ground. A small town shopkeeper may like to sit on the ground and deal with the clients. A farmer may like to go to the farm and work stooping down on the ground. So this is called floor activity. Anybody who is keen on floor activity and one-time operation, sir, I cannot afford to come to you again and again. I live in a place like Devariya. I cannot come to Delhi every day. I have to work there. I'll accept a Girdlestone, explaining everything to the patient. This second possibility, arthrodesis. A person who is a white-collared man.
Sir, I would like to one question in continuation of this from the dais. What is the optimum position of post-tubercular arthrodesis surgery? Optimum position. How much flexion, how much abduction, how much external rotation in male and female?
Dr. Meena has asked that question. What is the best position for arthrodesis of the hip joint? Yes. In an adult, the best position is 5 degrees of flexion, 5 degrees of external rotation, no adduction or no abduction. But
in adult male, sir,
the but is here. The younger the patient, you must give a little extra abduction, because with the passage of time, almost all these joints go into slight adduction. So give an extra abduction. Another thing, but if a patient is 12 years of age, give 5 degrees of flexion. Because with the passage of time, this flexion will also increase to about 15 to 20 degrees. In an adult, maximum flexion which can be given is 30 degree. In an adult, 30 degree abduction, 5 to 10 degree of external rotation, neutral position is the ideal. But this information, I don't think you will get from the newer generation of your orthopedicians, because they won't see these cases. My generation has seen these patients that in the long run, even if you have fixed these hip joints in absolutely neutral position, they have a tendency to get extra adduction deformity, and they have a tendency to get a little extra flexion deformity. The deformity, flexion deformity is permitted almost 1 degree per year, maximum 30 degree. If you want to use a formula, 1 degree of flexion per year, maximum of 30 degree. Obviously, you don't do fusion below the age of 13 or 14 years. So roughly 10 to 30 degree of flexion deformity can be given.
Thank you very much, Professor Tulli, sir. We'll conclude the first lecture now.
We can discuss the next question in the doubt clearance session at the end of this session. Okay? So please.
The second lecture today is from Professor Anil Mehtani, Lady Hardinge Medical College, New Delhi. He will be speaking on Perthes disease.
इसके लिए पॉइंट यहाँ पे ही आता है कि नहीं आता? ये इसको ये मास्टर ये करेंगे तो पॉइंट आ जाएगा. ओके ठीक. मॉर्निंग. Legg-Calve-Perthes disease. This disease was simultaneously described by 3 people from 3 different countries: US, France, Germany. So this name. Perthes disease is an idiopathic avascular necrosis of the part or whole of the epiphysis of the femoral head in a child. Unlike in adults, it is a self-limiting disease. The avascular epiphysis gets revascularized and the disease heals over a period of 2 to 3 years. This is the natural history of the disease, of course with some consequences. Etiology. The common age group for the disease is 4 to 12 years. A temporary and possibly repeated vascular insult is believed to be the major factor. Exact cause of insult is not clear. An anatomical fact that vascularity to the femoral head between 4 to 8 years is very critical may have some bearing. At this age, femoral head is supplied by a single vascular supply, that is lateral epiphyseal vessels. Metaphyseal vessels come late, they finish after 4 years, and around 8 years or so, vessel from the ligamentum teres come. So at this age, vascular supply is critical. Maybe that is one of the factors. Why are we discussing Perthes disease? What are the implications? Because of the avascular necrosis of the epiphysis, the head loses its structural rigidity. It is softened and may collapse. And if it collapses, it gets deformed due to the forces across the hip joint. As a result of the deformation of the head, what should happen? It will lead to pain and limitations of the movements of the hip joint. It also leads to development of secondary osteoarthritic changes in early adulthood. That will require a total hip replacement in 4th or 5th decade usually. How do we diagnose this condition? The condition is suspected on clinical examination, but the diagnosis rests on X-ray changes. Clinical picture, typically a boy, 4 to 12 years old, peak age is 6 to 10 years. In our country, peak age is around 8 to 10 years, little older as compared to the Western world. Boys are affected 4 to 5 times more common than girls. Usual complaint, initial stage, mild to moderate pain, and child starts limping. But symptoms are often mild, so children usually present late to us. At that time, the characteristic presentation described for Perthes is a painless limp. The child, unlike in tuberculosis, appears hale and hearty, comes running, walking to us, not sick. Hip also looks almost normal, maybe mild wasting, contrary to tuberculosis. On examination, the main finding is some limitations of the movements of the hip joint, usually painless unless it is synovitis stage. Abduction and internal rotations are usually more limited. There may be axis deviation. Axis deviation means when you flex the hip, it obligatory hip goes in external rotation. Normally when you flex the hip, the knee touches the opposite shoulder. Here it goes into external rotation. There may be some gait changes, antalgic or 10 lumbar gait depending on the disease. Initial stage is antalgic. Late stages, when disease is almost worn out, 10 lumbar gait because of some changes. This condition needs to be differentiated. Sir, Dr. Tulli had already told this. Transient synovitis, tuberculosis, rheumatoid, slipped capital femoral epiphysis in early stages. Epiphyseal dysplasia, sickle cell disease when disease is bilateral, these also give the same picture. Radiological examination, simple. What do we need? We need X-ray pelvis, both hips AP view, X-ray frog leg lateral view of the hip joints. These are the two X-rays we need to diagnose the disease. The natural history or the pathology of the disease passes through 4 distinct stages which are clearly delineated on radiographs. These stages are, first stage is the stage of avascular necrosis that runs for about 6 months or so, 6 months plus minus 3 months. What happens in this? It is avascular epiphysis, so it stops growing. Changes are very, very subtle. Epiphysis might look small. There may be some increase in the density of the epiphysis. Joint space characteristically in Perthes looks enlarged. Reason, one is the synovitis. Second, it is the epiphysis which is affected. The cartilage around the heads which makes the joint space that is thickened because it gets its nutrition from the synovial fluid. Second stage is this stage of fragmentation or revascularization. What happens here? Epiphysis starts looking fragmented. This is because of the growth of the newer vessels which come for regeneration and vascular connective tissue, plus there is resorption of the necrotic bone. So that makes the epiphysis fragmented. This stage lasts for about 9 months or so, plus minus 4 or 5 months. Third stage is the stage of healing, or we call stage of reossification or regeneration. This lasts little longer, maybe around a year or more. In this case, healing starts, new bone starts getting laid down, so there is some patchy sclerosis, signs of new bone formation. The final stage is stage of remodeling, in which head reforms, bone density is uniform, and the final shape head takes till growth is complete. This is the epiphysis, the joint spaces appears to be little increase. These are just subtle changes, sometimes very difficult. There is a little increase in the density over here. This is the stage of fragmentation. This is the epiphysis. This is getting eaten out here. See here, see here. This is because vessels have grown, bone is getting reabsorbed. This after fragmentation, there is a new bone formation here. This is getting replaced by the new bone. And this is the final in the healing. The head has deformed. It's become almost flat and deformed. There are other radiological changes also. Metaphyseal changes. Metaphyseal cysts are there. See here, these are the metaphyseal cysts. They show a poor prognosis of the disease. There are changes in the physis also, because physis stops growing. When the physis stops growing, neck becomes short, neck becomes wide, and the physis also tries to become horizontal. It is almost like this. Here the physis tries to become horizontal. Because neck stops growing, greater trochanter becomes elevated. Physis stops growing, neck stops growing, so greater trochanter becomes elevated in these cases. This is greater trochanter that is elevated here. This leads to the 10 lumbar gait. Severity of the disease. How to find the severity of the disease? Severity of the disease or the extent of the epiphyseal involvement, because on the severity of the disease depends the prognosis of the disease. Ultimately, contour of the head which we are going to expect. This is again judged by radiographs. So many classification systems. The most popular is a Kettle classification, which was probably one of the first ones, and recently the more popular one is a Herring lateral pillar classification, which are commonly used. Kettle classification, depending on the severity, it is divided into 4 groups. Judged on radiographs, AP and frog leg lateral views. Group 1, anterior portion of the ossific nucleus is involved. In group 2, less than 50% of epiphysis is involved, anterocentral part usually. Group 3, most of the epiphysis is involved, more than 50%. It gets fragmentation, collapses, metaphyseal changes also. Only posterior part of the epiphysis stays spared. So anterior is first to involve, posterior is last to get involved. Group 4, whole of the head is involved and it gets sequestrated. Group 1 and group 2, they carry a favorable prognosis. That means in these cases, we expect finally, usually a spherical outcome of the head. Group 3 and 4, they carry an unfavorable prognosis. That means we don't expect a spherical head at the end unless it is treated. We expect a deformed head in these cases. All this classification system is done little late in the disease. That is done in the stage of fragmentation after about 9-10 months or so. So this is a representation. This is lateral 1. Anterior part of the epiphysis is involved in frog-leg lateral view. AP view you can see like this. Anterior and central part gets involved. Group 3, most of the epiphysis is involved, only posterior part is spared. Whole of the head, this whole head is involved and head has become flat, sequestrated or flat. Lateral pillar classification, this is more simple, more commonly employed nowadays. This lays importance on the structural integrity or the height of the superolateral part of the head of the femur, which is principal load-bearing part of the head. On AP view, the femoral head is divided into 3 pillars by the lines at medial and lateral edge of the central sequestrum which is formed, or otherwise you divide the head into 3 parts. 3 groups. Group A,